Welcome back after the break. In this chapter we're going to talk about some practical issues.
Specifically, how to acquire a tricuspid regurgitation signal and what the pearls and pitfalls are.
We have been talking about reliability and accuracy of measurements of SPEP. And the most important thing is to get a good signal of the tricuspid regurgitation. Have a look at this selection of 4 patients. On the left, you can see a patient with hardly any tricuspid regurgitation signal. And it would be very unwise to try to measure here. You'll never get an accurate measurement. If you have a look at a patient here, you can see that this signal is certainly better than on the left side, but it's still not perfect. You probably won't have any difficulties to measure TR velocity here correctly, but still the border is not precise enough. Have a look at this patient here. You get a perfectly shaped signal of the tricuspid regurgitation jet, and that's where you can measure correctly. So try to get the TR signal as good as possible. Thomas is going to show us a specific situation.
This is a situation where it's very problematic to actually quantify pulmonary hypertension or pulmonary pressure because, as you will see, the regurgitant jet is very complex and eccentric. The patient has prolapse of the tricuspid valve, and we see that the jet probably moves out of the imaging plane, either towards the front or towards the back, so we cannot really see in which the direction of the jet is going. We can see the origin quite nicely, and I'll show you what happens if we put the continuous wave Doppler spectrum inside. What we have here is we have a spectrum that shows this tricuspid regurgitation, but we do not see how the curve really continues. Now it could end somewhere here, but it could just as well end somewhere down here. So in reality, the pressure that we would then calculate would vary greatly and would not give us would give us a large measurement error. So in this situation, I would not measure pulmonary pressure.
So in the previous example, you saw that it can be difficult to measure the TR velocity if we have a very eccentric jet. But sometimes we have a problem because the TR signal is very weak.
And you get an example here on the left side. No matter how you tilt your probe, you can't acquire a better signal than that. And it's certainly no point trying to measure it here. So what we can do is take contrast, and what we use in everyday clinical practice is just agitated saline. And what happens is that for a short period you get a truly enhanced signal of the tricuspid regurgitation. And you can certainly measure here, but be careful, don't take the sharp signals here because they obviously exaggerate the velocity, but the cutoff is somewhere here. In contrast, we have no difficulties getting a proper CV Doppler signal in this patient. This patient has got severe tricuspid regurgitation, but still we have got difficulties assessing the SPEP. Have a look at the CV Doppler signal on the right. You can see a typically triangular, early peaked shape of the TR signal, and the velocities are usually not very high, as in this patient.
Well, the reason why we have difficulties in assessing the pulmonary artery pressure is because we virtually have no gradient. The door between the right atrium and the right ventricle is virtually open, and we can't estimate the right atrial pressure. So, if you have a situation where you have a severe form of TR and you have the typical triangular shape, you cannot measure pulmonary artery pressure reliably.
We can not only calculate the systolic pulmonary arterial pressure, but also the mean pulmonary arterial pressure. And what we need for that is a good signal of a pulmonary regurgitation jet. And you have one here. And you take the peak velocity of this jet, multiply it by 4 to get the mean pulmonary arterial pressure. An alternative method would use the pulmonary acceleration time. And you've got the formula here.
Okay, Andreas, you've got a bunch of nice formulas here for us, but now, in reality, how often do you use them in your clinical practice?
Well, Tommy, to be honest, hardly ever.
So the key message is, yes, you can do it, it does work, but you do not really need it.
The same applies to the assessment of diastolic pulmonary arterial pressure. Well, you can find the formula in your fact sheet, but don't make things too complicated and get twisted in your examination. What is more important than fiddling around with calculating diastolic or mean pulmonary arterial pressure is getting the full picture of pulmonary hypertension. So, let's look for other signs. One of those is pulmonary acceleration time, and Thomas is going to show us in a demo how to acquire an appropriate signal.
Let's take a look at a patient with suspected pulmonary hypertension to determine if the patient has shortened pulmonary valve acceleration time. To do this, we need a parasternal short axis view of the pulmonary valve. Okay, so you have to tilt the transducer towards the pulmonary valve until you see the pulmonary valve. This is the pulmonary valve here. And then we'll put the PV Doppler spectrum right beneath the valve in the pulmonary artery and obtain a signal. And then we measure the time interval from the beginning of the signal until the peak of the signal, which is somewhere in the region of 139 milliseconds, which is normal. In other words, the patient does not have signs of pulmonary hypertension from the spectrum. In addition, we do not see notching of the descending part of the curve, so very unlikely the patient has some degree of pulmonary hypertension.
A few facts about pulmonary acceleration time. It shortens with elevated pulmonary arterial pressure, and it's valid for a heart rate of 60 to 100 beats per minute. And it may be normal in elevated right-sided cardiac output, a situation you can find in an ASD. Especially in situations where you can't calculate a good SPUP out of the tricuspid regurgitation signal, you can use pulmonary acceleration time to classify pulmonary hypertension. And values over 130 indicate normal pulmonary arterial pressure, and values under 80 indicate significant pulmonary hypertension.
In between, we have a bit of a gray zone. And don't forget that the signals are often not so crystal clear that you can really determine where the peak of the signal is. So remember, if you have values somewhere between 100 and 130 milliseconds, you can only say that there must be some degree of pulmonary hypertension, but it's very difficult to really grade how severe pulmonary hypertension is.
In some cases, you don't even need Doppler investigations, but a 2D image will give you a hint that there must be pulmonary hypertension.
In this patient, in the short axis view, you will notice that the septum shows flattening, and that this flattening is present both during diastole and during systole. So the reason for this flattening of the septum can be found if we look at the four-chamber view. We have severe tricuspid regurgitation here. And we also have elevated flow velocity, which means the patient has pulmonary hypertension.
In this patient with pulmonary hypertension, you can see a dilated right ventricle with a reduced function. But you can also see a flattened interventricular septum. And that's what we want to focus on, because the septum can be flattened in systole, diastole, or in both. And the reason for that is either pressure, volume overload, or a combination of both.
One can also quantify the degree of eccentricity. You can do that by taking the longer diameter and dividing it by the shorter diameter. This is sometimes helpful if you want to follow up patients or if you perform studies on patients with pulmonary hypertension.
Right ventricular hypertrophy is another sign of pulmonary hypertension. And in some cases, as in this patient, the thickened right ventricular free wall is pretty obvious. Unfortunately, that's not always that easy to measure, especially in right ventricles that are hypertrabeculated.
And there's also one thing that you should consider. if you have right ventricular hypertrophy, it does not necessarily mean you really have pulmonary hypertension, because there is a setting where this is not true. Do you know which setting I mean? I'm sure you all knew the answer. It's pulmonic stenosis.
2 more signs you can find in 2D imaging. First, pericardial effusion. Well, obviously not every pericardial effusion is due to pulmonary hypertension, but those patients with pulmonary hypertension having a pericardial effusion have a worse prognosis. On the right side, you can see a dilated pulmonary artery. The normal value would be between 1.5 and 2.1 centimeter, but I find it quite helpful just to compare it with the root of the aorta, and it shouldn't be greater than that.
And the presence of a dilated pulmonary artery is not irrelevant. I've seen patients with pulmonary hypertension who died because of rupture of the pulmonary artery.
So in conclusion, what denotes severe pulmonary hypertension? A high TR velocity and consequently a high calculated SPUB. A dilated inferior vena cava without any respiratory changes. A dilated and hypertrophied right ventricle, a flattened interventricular septum and pericardial effusion, and a dilated pulmonary artery.
So in summary, if you're assessing patients for pulmonary hypertension, always use an integrative approach. The more signs you have to look for pulmonary hypertension, the more sensitive you will be. It's like having more antennas.
And it's really important to detect pulmonary hypertension early, as it makes a big difference in treatment.
Andreas, what is your next chapter going to be?
Well, the next chapter is called Diseases of the Right Ventricle.